Thank you, everyone. Thanks, Marvin.
Right. All right. Thank you, everyone. My name is Mervyn. I'm one of the core surgical trainees. I was just in the ENT department in the previous rotation. And in the next sort of 12 minutes, I would like to discuss and provide teaching on dealing with any post-operative thyroid and neck hematomas that may happen in this hospital. Okay. The reason why we're providing this teaching is because we've recently done a quality improvement project where we've sought to identify how well individuals across the hospital feel in managing with neck hematomas. And essentially, the lighter shade is bad and the darker shade is good. And what we realize is that a lot of individuals, whether that's recovery nurses, doctors on the ward, theatre staff, felt like they had not had formal teaching on how to manage neck hematomas if they were to happen. And so, as part of this quality improvement project, we want to provide this brief teaching to give you the key necessary information on what you need to do and what you need to be aware of in the event of a neck hematoma. Okay. Now, these are the key learning objectives we will cover today. And the most important things that we want to get across is that we want you to understand the importance of treating thyroid hematomas. We want you to be able to describe the relevant neck anatomy, see the signs and symptoms of any potential thyroid hematomas, and understand keyly what to do if a thyroid hematoma was to take place. So, just very briefly as a background, I know a lot of us have got very big relations to ENT, but essentially, thyroid surgery is a very common procedure performed across the country, with at least 11,000 cases being estimated to be performed annually. In Lincoln, that's around 120 cases a year. So, it is a very common surgical procedure that we perform. Now, bleeding, or otherwise known as hemorrhage, is a common complication seen in any operation, but in the case of thyroid surgery, it is a very important complication to be aware of, with a sort of national incidence rate of 0.45 to 4.2%. In Lincoln, it's just around 0.5%. But the reason why it's an important complication to be aware of is because if it is not dealt with quickly, it can rapidly lead to airway compromise, which then can lead to hypoxic death. Now, nationally, we have a sort of mortality rate which is around 0.03%, but there are written and documented cases of individuals dying from neck hematomas that have not been dealt with quickly and adequately. And so there's been a national push to ensure that there's adequate teaching and the necessary equipment available to deal with these hematomas if they are to take place. And the recommendation from the British Association of Thyroid and Endocrine Surgeons is that staff, whether you're an FY, an SHO, a recovery nurse, a staff nurse in the ward, you should all be able to know how to deal with a neck hematoma if it is to take place. Now, the key things to be aware is that almost all of these hematomas, or most of these hemorrhages, occur within 24 hours following the operation. All right. 50% of them will happen within the first 6 hours. A hematoma after 24 hours is extremely rare, but it can happen. And so it's very important that we are all very vigilant, but also know the key steps to take to perform if this is to happen. Now, the reason why this is so concerning is essentially the sequelae, or the physiological sequelae, is this. Hemorrhage leads to a hematoma forming, which then leads to edema and compression, not just of the voice box, but also of the airway. And this edema and compression then acts as a sort of tourniquet within the neck, causing rapid airway compromise. And it's this airway compromise that then leads to hypoxia and unfortunately then cardiac arrest. And so these things need to be dealt with quickly and swiftly. Now, briefly, just the surgical anatomy for us that are not aware. The thyroid gland is a superficial gland found at the front part of the neck. It spans the second and fourth rings of the windpipe. And overlying the thyroid gland is a very tight space of, or rather a tight layer of fascia called the pretracheal fascia. And on top of this, we've got superficial layers of muscle called the strap muscles, as well as the platysma. Now, why are we mentioning this? The reason why we're mentioning this is because within the neck, all these layers can lead to a very tight space. And so if you've got bleeding that's happening within that tight space, then that can rapidly lead to compromise on the airway, which is why we need to deal with this quickly. And briefly, if you've been in theatre and you've seen this operation, essentially, superficially, you can see the area that the thyroid gland is located and the overlying skin. When an incision is made, you see the underlying strap muscles, which I mentioned. Then the thyroid gland sits underneath these strap muscles once they have been divided. And once the thyroid gland has been removed, what you can see underneath is the windpipe. And so again, this is all just trying to indicate that this is a very tight space, and if bleeding occurs, this needs to be dealt with quickly. So, when should you be concerned of a hematoma? And apologies, the slides haven't transferred as well as I'd wanted them to the hospital system. But these are key symptoms that key signs and symptoms that you should be aware of, and that should increase your clinical suspicion of a hematoma if you're dealing with any patient who has had a thyroid operation. Difficulty in swallowing or increased discomfort that the patient is reporting, an increased new score, and in particular, the parameters that you're concerned about are their oxygen saturation, swelling within the neck or bruising, increased anxiety from the patient, any increase in the respiratory rate or difficulty in breathing that is reported by the patient, and most importantly, any changes within their breathing in terms of phonic sounds, so stridor. These should all increase your concern of a possible hematoma. And if that happens, the algorithm that we're suggesting within Lincoln is that we give the patient high flow oxygen via a non-rebreather mask. We nurse them up at a 45-degree angle, and that's to promote venous drainage. And we arrange for senior review from the ENT team or the anesthetic team, whoever is closest. When should you suspect a hematoma? These are the key signs that we want you to look for to make you really think there might be a hematoma in place. Now, the triad that we're proposing as a triad of airway compromise includes a stridor that you can hear from the end of bed, desaturation from the patient, and difficulty breathing. The most obvious sign you will see is a very tense neck swelling, and that should all indicate to you that there's a hematoma that is within the neck that needs to be evacuated. Now, desaturation is a very concerning late sign. And so don't wait for desaturation to happen before you start escalating. If desaturation happens, it is a very late sign that indicates that cardiac arrest is actually impending. And so, as I've mentioned, these things need to be dealt with very quickly. If you notice any of these signs in the patient, then we're proposing to you that the priority in this patient is to reopen the neck, and that is to initiate the scoop protocol, which is what I am just about to mention to you now. Now, reopening the neck can be a very daunting thing to any individual, but it is a life-saving procedure, and any trained member of the team, whether that's a ward nurse to an FY doctor to an SHO, or a theatre recovery nurse, should be able to perform this in the event of a neck hematoma. Now, this should be done at the location where the patient is, and the patient shouldn't be transferred to theatre, and local anesthetic is not required. Now, what is the scoop protocol? So it is an acronym that stands for the following things, which is expose the skin, cut the sutures, open the skin, open the strap muscles, pack the wound. That is essentially what SCOOP stands for, and should be followed in the case of a neck hematoma. And so very briefly, the steps are as follows. Call for help. So in case of Lincoln, make sure you phone 2222. Make sure ENT or anesthetics are on site. Locate a rescue box, which will be available in key areas. Then, as I said, remove the steri-strips, which will be on top of the patient's skin, cut the subcuticular sutures. All this equipment will be available in the rescue box. Push your fingers into the wound, open the wound up, expose the strap muscles. If there's a slight suture that's closed the strap muscles, just cut that open and get towards the windpipe. And after you've exposed the strap muscles, expose the trachea and evacuate any hematoma that is there. And after that, place a simple pack on the wound and wait for surgical urgent surgical review. Now, within these rescue boxes that we will be distributing out amongst the key areas of the wards and theatres, you will have a stitch cutter, archery clips, gauze, scalpel and forceps, which is essentially saying all the necessary equipment for you to initiate the scoop evacuation will be within this box, and it will be clearly labelled in the ward. Now, this is a very brief video, which unfortunately we won't have time for, but you'll find it on YouTube. And essentially, it is an individual just highlighting to you the key steps. So exactly, removing the steri strips, opening the wound by cutting the subcuticular sutures, exposing the strap muscles, dividing the strap muscles with your fingers, and then getting towards the windpipe, which in the case of a neck hematoma will be filled with blood and needs to be evacuated. And thereafter, just placing a simple pack on the wound. So very key points from this teaching session is if you're concerned regarding a hematoma, call for senior help and ask for an urgent review. If any of the signs, the DSATs acronym, are positive, that warrants a review, and so ask for a review. If you see any signs of an airway compromise, then the likelihood of a neck hematoma is very high, and so you need to phone 2222, get the cardiac arrest team, airway crash team on site, and perform evacuation of the hematoma. And the most key take-home message from this is the following. A scoop intervention or scoop evacuation is a life-saving procedure and should be done quickly in the concern of airway compromise. These following protocols will be available in the intranet following approval to give you, again, further details and guidance on how to deal with these neck hematomas. You will see these posters around the sites of the patients who are having thyroid surgery, as well as within the rescue boxes. So there will be plenty of guidance in the event this was to take place. And these alert cards will be with patients who are having thyroid surgery, and that is just to be a visual reminder that there is a risk of an airway emergency and that all members of staff should be aware. These are my references. We'd just like to give a bit of special thanks to the named individuals in the slide for helping with this quality improvement project. And we're happy to take any questions.
Thank you for this last presentation.
Thanks, Marvin. Thank you.
Thank you very much, guys. From just my experience, nobody will blame you to open the neck. Everybody will blame you if you can't open. You have a couple of minutes. You can lose a patient. Everybody should be deal with it. Talk about it if you're not confident. Just open the neck. Anybody has an idea why they get airway straightforward problem? Anybody know why? Why the hematoma causing an airway? The cartilage is very strong. It shouldn't compromise by the hematoma.
Because of tracheostomy in many cases.
No, tracheostomy is very rare.
I mean,
Why? Why people get it? Why usually in the first 6 hours? Because the hematoma compromise the venous drainage to get submucosal edema straightforward. And that's why it resolves straightforward once you release the pressure on it. There is no compromising the trachea itself. It is a venous congestion. Yeah. Do you agree, Mr. Salama, with me? And I have my own way. Me and Mr. Salama, we built it over years. He's more senior than me, better than me, faster than me. But we do double Valsalva. We do double Valsalva techniques. So we get one for the good luck, second one for the NHS. And I believe we have a little bit less than the guidelines.
I believe we are far less than the national figures for the hematoma. And for us as a team, we put the drain less and less, yearly in nothing more than 10% or 7% of the cases. Most of the cases pass without the drain. And our colleague who help us, our witness, we don't do the drain. And I believe the trainee who visit us or work with us from other trusts, it was a noted less and less drain. The only thing is the trial or consider thyroid surgery as a day case based on the fact most of the bleeding happens in the first 6 hours. it's not acceptable to leave the only phase two. You get it's or one consultant going get in Liverpool, but no other person considered for a day surgery yet.
Thank you for this to come to present today the transnasal laryngeal biopsy. I'll leave the mic.
Thank you, Mr. Bahamer. Thank you, Mr. Ibrahim. Glad to be back to Lincoln for courses after 1 year in Nottingham. Still, Mr. Ibrahim with the same passion, which is great. I'm a head and neck registrar here, for the who doesn't know me. Great honor to be the assistant of Mr. Salam over 5 years, almost 5 years. Today, we are going to talk about a new device, a new technique in our trust. We nearly to use it. It's transnasal laryngoscopy and biopsy in clinic setting. A very quick orientation about the larynx voice box. We need to know that the larynx orientation exterior, interior, for sake of radiological assessment as well as diagnostic procedures. So it's a cartilaginous structure which has three umbilical cartilage known for all of us, as well as orientation of the inlet of the larynx, which is mainly in the muscle and cartilage and lined with mucosa. It's very important to know the anatomy of the larynx in terms of if you're reviewing a patient in emergency or elective setting in X-ray, like lateral use of neck tissue or CT scan axial cut. You have to be aware about this structure interiorly and exteriorly to know what's going on. Also, it's very important to know that the anatomy of the larynx is part of its main dual function of passing the air current to the windpipe, as well as protection of choking and safe swallowing. So any problem with the larynx, patient may have choking. Also, the voice production, which is the main function of the larynx, which is a voice box organ. Now to the most important point here, which is we are concerned or are targeting today, the inlet of the larynx. Larynx have 3 parts. We have to be aware in any diagnostic surgery about this part. So false vocal cords and the true vocal cord are the main structure you have to identify to be able to judge if the wave is taken from here or there or over there to know whereabouts you are. So there is a vestibule up to the false vocal cord ventricle between the false and the true vocal cord, and then subglottis area, and obviously the vocal cord if you're taking a biopsy. So orientation of the inlet of the larynx is much better. It's a very important point, and is much better to be achieved through transnasal laryngoscopy because the sitting position of the patient is very important to be obviously have a look into the different parts of the laryngoscope, even rather than the direct laryngoscope under general anesthesia, and we'll come to this point later. So what is transnasal laryngoscopy? It's a clinic setting procedure. Could be done under local anesthesia. We aim to shorten the time awaiting the procedure, take a quick biopsy, get early results via clinic setting. It's similar to transnasal flexible nasal scope procedure that all of us doing it in the clinic, but advanced a bit to be able to take a biopsy and to do some sort of enhancement of the way that we are treating the patient or managing the patient. The good thing, clinic setting and under local anesthesia. So indication, basically for any diagnostic surgery, we aim for do that for distinguish between benign lesion and sinister lesion. This is at the main part, and also could be there to do excision of any benign lesion. Also, it's very important after this point in voice clinics and further assessment of the voice to do some procedures, even by injection, laryngoplasty, or even assess the voice box in terms of dysphonia with unknown reason or unknown or no apparent lesion. So transnasal laryngoscopy is a very good way to have a very wide look of the larynx without neck positioning problem you might have meanwhile you are doing under local anesthesia. The patient, if cooperative, it would be nice imaging and the clear imaging of the voice box, and then you can proceed accordingly and see what's going on there. Sometimes subglottic lesion, it's easy to be examined during clinic setting much better than under general anesthesia. and meanwhile the tube inserted in the voice box. Contraindication, we are here talking about a couple of things. Here, this is the absolute contraindication. We are not able to do this procedure anymore in case of allergies for topical anesthesia. If there is significant mechanical obstruction in the, basically in the nasal cavity, also if the patient has any bleeding disorder, this will not be able to go ahead with that. And basically the patient preference, some patient is anxious enough to have this procedure under local anesthesia. Some limitation of the this procedure, I wouldn't say this is a relative. I would say this is a relative contraindication, but this is a patient factor, surgeon factor. Surgeon factor as me, that I'm not that big fan of these things, but still some other surgeon would like to do that and find it's very effective for them. So surgeon experience and the patient factor. If some patient with gag reflex is not responding that much with local anesthesia, even by oral spray or nasal drops, so this might may a big limitation or a challenge during doing the procedure, because you will do lots of intervention during the procedure. This is part of the equipment could be used during surgery, including the set or the box of the stack, coffinal cane, which is very important for gag reflex suppression, basically screen as well as atrovine or any nasal decongestant to make a better passage of the big transnasal laryngoscope, and then the biopsy forceps. This is an example of how important to perform a transnasal laryngoscopy biopsy, which may reflect on our daily practice. This is 60 years old, male patient, has T3 and not laryngeal cancer. And this patient has been treated non-surgically, T3, with chemoradiotherapy. And in the post-treatment bed, it showed equivocal uptake at the right supraglottic area, which is the genuine origin of the cancer. You can't imagine how the patient will suffer during this time. He's awaiting for this post-treatment bed for 12 weeks, and he is awaiting the results of the post-treatment bed. Unfortunately, the bed come back inconclusive in such a problem. So it's equivocal. You need, if you are going in the normal pathway, you will see the patient, book the patient for microlaryngoscopy and biopsy. This will take 3, 4, 5, 6 weeks to be done, and then 3, 4 more weeks to awaiting the result, and the patient is burning, waiting for the result. And here we can imagine how important and effective the transnasal laryngoscopy to, in the same setting in MDT clinic, after reviewing of the MDT results, to take the biopsy in 2 or 3 weeks, we can get back the result and arrest any confusion about that. So this is one point that, or a better explanation of how important to apply this kind of procedure in our practice. I mean, in fact, today I have had a quick chat with our theater coordinator, spoke about with Dylan, as well as Cameron Brown, about how many diagnostic laryngoscopy we have done over the last year. It's about 185 procedure we have done. Imagine how can we reduce the waiting list if we do this kind of procedures in a clinic setting.
Things much higher. Many of them are coded under.
Yeah, that's right. It's unspecified code.
Yeah.
The main code we walk through, it's not, it's
Most of
unspecified.
our
That's
cases
right.
go to band in scope, so
Yeah.
I would imagine the numbers.
I think we can double the number.
3 volts at least.
Yeah.
Because that sometimes it's laryngoscopes, band endoscopy, so
That's right. Also,
It's
yeah.
there.
Band endoscopy for all laryngoscopy, even I am looking for
Not
band
only
endoscopy.
Lincoln's,
Yeah.
there's also
They're
three
coding
trans-
most of the time band in scope.
Yeah. So this is a very important point, how the transnasal laryngoscopy biopsy will relieve the congestion on the waiting list and make the process of diagnostic procedure is better. Thank you very much.
Thank you.
Any question? Sorry. Any question?
You have experience with that.
Yeah.
20 book, because my opinion, transnasal don't get the results. Back to see. Our experience is based on the resource patient waiting. Sometimes I get the truth. Sometimes you can wait from. I would imagine if originally we keep the appointment later. This we don't.
Oh, yeah. I believe in my experience, not.
Don't come back as negative. Because negative and close the case.
Yeah,
or the-
yeah. They are very selective to choose the patients.
This is the second
This is the
thing.
point.
If
This
you
is
have a
Indian experience.
cauliflower mass,
That's right.
whatever you touch, you will get some
Yeah.
tumor cells, some leukemia
Yeah.
or very tiny
Yeah.
mass.
Yeah,
Many times, if you do, I think the biopsy
Yeah.
get come back as
yeah,
negative.
that's right, Mr.
And you scope it again, you think, no, I'm going back to the.
Yeah.
The old days, we used to do it with the bronchoscope when there was anything, we use the bronchoscope, select the cases who are not fit, who are not fit for anesthesia.
Mhm.
Used to ask our colleagues at the respiratory chest to give us the bronchoscope, which is the same idea anyway.
Yeah, yeah.
Leaves the new scopes, which is the
Narrowband imaging,
yeah, narrowband imaging.
a very good idea about what you can target.
Yeah.
Give you
Yeah.
an idea.
That'd be useful, yeah.
It's very advanced.
Well, that was the thing that.
Yeah, I'm very aware.
Yeah, and there's a lot of mindfulness, breathing, it's
Right.
interesting for the patient.
Yeah, yeah.
A lot of patients do faint and they get very, very anxious.
We still do it in the theater for these reasons. We are not fully, or I don't in my list couple of cases, I would recommend at the moment in Lincoln, we do it inside the theater, because there is other factors and those people has a lot of comorbidities.
Yeah.
We were not able to control it, and we keep it at the moment for the cases which we cannot be in other things in the city. For instance, time facing us, Well, again, it's complex, it's more complex at the moment.
And also the staff nursing clinic in Nottingham are very helpful, very supportive, and have a good experience. Such thing as not all of them is doing that. It was Mr. Strauss.
We are facing people who's a training,
Yeah.
So we try to do that in the theater at the moment, but we wish in the future we can consider an outpatient theater
Yeah.
list,
Yeah.
Any question?
Thanks, sir.
You're welcome. Mr.
I'd like you to be at the end, so you take your time. So that I'm trying to push those people to finish early. So
I
can't, the file's too big.
it's very big, so you're gonna down.
Too many pictures.
بدأت اتحمست وجيت وانا
Yeah, okay, so I'll just keep the. Okay, thank you, Ahmed, for your presentation. So we're gonna go for the second one. Adam McNair with this will present it regarding to the surgical tracheostomy. And then we will go for the complete care after this with Sue.
Guys, if you have people who are online, our colleagues, if you have any questions, kindly please write it on the chat. Check if we have any chats questions.
Yeah, I often mind, so I'll do it. Thanks, Adam.
Thank you, Mr. Ibrahim. Right, so I've been asked to present on the surgical side of adult tracheostomy.
in front of a room of people that have done far more tracheostomies than me, and at least 6 people that taught me how to do trachees. So if I say anything wrong, I'm sure someone can correct me. Tracheostomy is a surgical procedure to establish an artificial airway via an opening in the trachea, and the created airway is maintained by the insertion of a tracheostomy tube through the anterior neck. We do it for a multitude of reasons. The vast majority of time, this is upper airway obstruction. So whether that be a tumor, whether it's infection, trauma, very, very rarely foreign bodies, vocal cord paralysis or subglottic stenosis, anything that blocks up the area above the trachea, make an airway below it so that the patient can breathe. Other indications are prolonged ventilation, so patients in ICU, reduce dead space, make it easier to ventilate them, secretion management, or as part of another larger procedure, so major head and neck surgery, some of the things the maxillofacial guys do, or laryngectomies. Brief anatomy lesson. The trachea is a pipe composed of incomplete cartilaginous rings extending from cricoid down to carina. It's covered by the thyroid isthmus at rings 2 to 4, which are the important rings for your tracheostomy, so it has to be dealt with at some point in the operation, and is deep to your sternohyoid and sternothyroid muscles, which are 2 of the 4 straps. So these are things you have to get past if you're going to do a tracheostomy. Common carotid arteries lie lateral, and you shouldn't get anywhere near those if you're doing it right. And the innominate artery crosses the trachea as it arises from the aorta. Occasionally, you can get a thyroid IMA artery in about 4% of people, which works its way up the midline of the trachea, so that can bleed considerably if you catch it. So what do we need? Just about every hospital should have a tracheostomy tray that has all the equipment in it that you need. Generally, we say a size 8 tube for men or a size 7 tube for women, but that can be adapted based on size of patient, size of neck, and then consider things like longer tubes, like the adjustable flange tubes for patients with very thick necks. And always have the next size down ready, unopened nearby, just in case your tube is too big when you get to the key bit. A fibre optic scope for the end of the procedure. So here we have glider scopes, elsewhere they have ambuscopes, can be very useful to have a look down once you put the tube in and see that you're in the right place. And also you can then measure your distance to carina. Positioning wise, put the patient supine with the neck extended. So a shoulder roll and head ring tends to be the best way to do this. Mark your thyroid notch, cricoid cartilage, and that should say sternal notch, not sternoclavicular joint. So mark your surface anatomy, and then mark your incision site, which should be around 2 centimeters below the cricoid cartilage. I tend to end up drawing an awful lot of things while the consultant looks at me like, why are you marking so many things? Just get on with it. The patient can't breathe. Preparation. So Corhex or iodine-based surgical prep from chin to chest, and then square off the drapes, making sure that you leave the head end access for the anaesthetic team. So avoiding sticking any of the sticky bits to the tubes for when you get to that key bit, especially in sort of dramatic airway obstruction patients where you need to do all of your switching over quite quickly. And then anaesthesia wise, these procedures can be done both under general or local anaesthetic. Local anaesthetic, if you have an upper airway obstruction, that means you can't get an ET tube in from the top end. Think about things like bupivacaine with adrenaline or lignospan, and go right down onto trachea with your local anaesthetic to minimize patient movement and discomfort when you're doing the procedure. And then incision, I like a 4 centimeter incision. My bosses like it to be smaller, but it makes it easier for me. 1 to 2 centimeters below the cricoid cartilage. Some people do use vertical incisions. I've personally never seen that done in adults. There you go. So we go through skin and then down through subcutaneous fat and platysma. So your initial incision should get through those layers. Some people like to raise a bit of a subplatysmal flap as well, or you can put in a self-retaining retractor at the level of platysma just to create that space. We then use Langenbeck retractors to keep it work layers down, and you want to use blunt dissection in the midline until you reach the thyroid isthmus. So separating layer by layer with an artery clip, using the Langenbecks to peel back, bipolaring as you go, making sure that there's no blood at all. Mr. Salim doesn't like blood. He tells me that from time to time.
No peanuts.
Certainly no pledges. Yeah. Bipolar, cut layer by layer until you reach the isthmus. As you go down, keep palpating the trachea. It can be easy. If you've got 2 people doing retraction from either side and one of them's twice the size of the other, it can be easy to start to disappear away off to one side. So keep checking your trachea as you're working down. Make sure you're staying in that midline and staying on top of the trachea. Once you get to thyroid isthmus, there are a range of ways you can deal with this. I will talk about my favorite way. I please don't want to anger any of the bosses here. So skeletonize the isthmus, separate it away from the trachea. So bipolar at the top and bottom of the isthmus to get your artery clip in, open up so you can see trachea under it, and then split it and lift it up off the trachea. A right angle or an artery clip, something to get your isthmus isolated, clip either side of it. And then I love using the ligature for any opportunity. So separate it with ligature, and then your belt and braces approach to make sure the isthmus doesn't bleed would be transfixion sutures, something like a vicral suture. Other people use bipolar, monopolar, all sorts. The key thing is hemostasis of the isthmus. If anything's going to bleed in the tracheostomy, it's going to be the isthmus. It loves to bleed. So either lots of cautery or very secure sutures, or a bit of both. You should then have a trachea in view, and you want to make sure it's nice and clean so that you know where you're going. So clean it up with bipolar, maybe with a pledget if you can get away with it. Until you can see cricoid, and then your first, second, third rings is the area you really want to be able to know where you are anatomically. When you're making your cut into the trachea, the first ring should be avoided. The higher you are, the more likely you are to cause subglottic stenosis, which can affect your ability to decannulate the patient in the long term. So second or third ring for your incision into the trachea. Some people say third or fourth. It can also depend on if they've got a very short neck and you're getting close to sternal notch, you're getting close to important clockwork lower down, you may need to go a little higher. And you've got to think about tube changes in the long term if it's going to be very difficult to get a tube in if you go too low. So that sweet spot tends to be second or third ring. Lifting up with a cricoid hook so that you can see and access things, and you've got a nice secure hold on the trachea when you're going to put your tube in, can be very useful as well. There's lots of ways to go into a trachea. I like a window. So take an Alice forceps, make a sharp cut above and below, hold your little ring that you're going to take out. You want about a third of the width of the trachea itself, maybe a little bigger. Think about the size of the tube you're putting in. Think about the size of the tube you're putting in. It needs to be big enough to accommodate the tube, but as small as possible. You'll see Bjork flaps from time to time. Personally, I find that leaving a flap that may close gives me anxiety, so I don't do them. And then other things are things like vertical slits, but lots of different ways to approach it. If the patient's intubated at this point, you want to deflate the cuff. You want to advance the tube as far down as it can go towards carina so that you don't stab straight through the cuff when you enter, and make sure the anaesthetist knows what you're about to do. So cuff down, advance the tube, reinflate the cuff, and then make your cut. You want to be careful with any kind of power tool at this point. There is a very small risk of airway fire if you go into a trachea that's being ventilated with anything like a monopolar. Before you're making any cuts in the trachea, ensure your tracheostomy tube is prepared. So even if it's already been prepped, check the cuff again, make sure it's got the trocar in there, make sure it's lubricated, all ready to go. And then remove the ET tube slowly under direct vision. So talk to your anaesthetist, keep your eye on what's going on. Once the ET tube is out to the point where you can see below it, put the tracheostomy tube in. The ET tube can stay above. It doesn't need to come out fully, and it means that if something does go wrong with the tracheostomy tube, you've got a tube that you can just push straight back in. So you don't actually need to take the ET tube all the way out until you're ready to close up. Put your tracheostomy tube in, and then one person's hand stays on that tube until it's stitched in. So if you've got an SHO or a junior reg with you, you tell them to keep their hand on there if they value their career. Take your trocar out, put your inner tube in, inflate the cuff, and then transfer the anaesthetic circuit on. And that should all be nice and slick and quick. And it sometimes isn't, depending on the situation. And then check for your CO2, check for a leak. Then your ET tube can come out and you can secure your tracheostomy tube with silk and close any excess skin you've got with Prolene or equivalent sutures. Put on your trachea tapes and dressing. Lift the head off the head ring to check your trachea tape tightness. It will feel tight because the head's back like this. You lift the head up and it's actually very loose, and then properly secure it. So you've just got one finger's worth of tension, one or two fingers worth of tension in the tapes. So they're helping keep things in place without choking the patient. I'm not sure how much you're going to talk about complications. So I won't go into detail on all of these. Lots of bad things can happen with tracheostomies, and we need to know how to deal with them. And I think that's what Sue's going to talk about.
Maybe not an airway fire, but
I briefly mentioned airway. If airway fire happens on the ward, something's gone really wrong. Any questions?
Thank you for this last presentation.
Adam, if you are communicating with anesthetist and you are compromising intubated patient, ask him to do a bit of apnea after
Okay.
push the tube down.
Yeah.
By apnea.
Yeah.
And it's when they are not.
I believe we have a lot of number of trachea here. We don't get a lot of support in intubations. We've been being involved in these difficult times. Where can crush tracheostomy? I think Dr. Aisha said the last time we're facing very hard patient. Patient cannot lie flat, had the tracheostomy while he's sitting position. In the meantime, his thyroid cartilage just above the sternum. Like the sternal notch, we have to retract. We have to retract his thyroid cartilage. On his trachea, thyroid is in chest also. Yeah,
I've done it.
so I done the bubble.
You can see the RCB is there.
Yeah.
You got members of the agency here.
You done trachea?
Yeah, several.
Yeah, several. Good news for you, not for us.
Yes, baby.
Yes, it was to say that after finishing tracheostomy, we need to always do like use the endoscope.
Yes.
Yeah, examination, make sure the trachea and the windpipe, it's fine.
Yeah.
And the distance between its end and the carina, which is quite essential.
Yeah.
For the anesthesia. And,
These are things which is, there's much change in the trachea by time, and speaking about what is the breath inside UK versus the breath is before or anywhere else. As you mentioned yourself, any trainee, you see a lot of people, and then you develop your own. You mentioned the big one, and I adapting big one because the key for everything, and anybody working with me, key for everything is good exposure. Once you have a very good exposure, you will never lose your way. And this is number one. Cutting the thyroid is something I developed here in UK before we wasn't, but it's not part of the procedure. Some people may not cut the isthmus, but this jeopardized get a call middle of the night, tracheostomy tube is out, and we don't find the hole anymore. Because it becomes a common practice. What else is a common practice is a stage suture. Some people make a stage suture both sides and get it outside silk. But remember to make the knot outside, not inside, otherwise you wouldn't be able to get it out. Yeah. Make the stitch not so tight. You don't get an emphysema, you get a tight thing. And for the window, yes, this is a common practice to have the window. I do the lower flap and stitch it in the subcutaneous, which make a clear path. You slide the tube that on, but be sure you stitch it very well. Yeah. Not to close the tracheostomy, but I make a very nice path. This not the common or not the recommended way. Thank you.
Thanks, Adam. So last but not the least, so thank you so for coming from Nottingham, especially for this training day.
say thank you. Some of the slides I'm going to flip on that aren't applicable because I know Adam's covered a lot of them. But so my name's Sue Mason-Garb. I'm an airway nurse specialist. I'm based at QMC, although me and a small team, we look after all of the neck breathing patients in this room. So we look after laryngectomy and tracheostomy patients within a hospital setting, and we also support them in the community. So just a little bit of background. I've worked in ENT for over 30 years. I've been a ward sister for 16 years. And as being a ward sister, I personally found that a lot of laryngectomy and tracheostomy patients were very late being discharged home. Nobody trained them appropriately. When they were sent home, they're often readmitted within a week. GPs obviously are not specialist enough to be looking after these complex airway patients when problems arise and they're told to go back to ED. Obviously, on the back of the NCPOP report and the National Tracheostomy Safety Project, there's a national drive for neck breathing patient care to be improved. And what we're finding was that there was avoidable deaths and high level incidence of neck breathing patients on hospital wards. Not all tracheostomy patients end up on an ENT ward, and they often end up in multiple specialties, and the care delivery from ward to ward and trust to trust is very variable. So there was a demand for better care, and obviously we saw that the patient numbers increased year on year. Certainly our neck breathing patients, we have a 20% year on year increase. And there's often a massive backlog in patients being able to get them home. It's very easy to put a tracheostomy in on somebody, but then we realised when we've dealt with the emergency situation or they're in an airway compromise, they're 90, they're partially sighted, arthritic and live alone. What do we do with these patients? There's very few care homes to look after them. Really, support is very minimal. So the role of the service, so I piloted the service 6 years ago and we set the service up. So we support patients from diagnosis through treatment on the ward, and then we see every laryngectomy and tracheostomy patient in their own home within 2 working days of discharge. That allows us to be able to check they've got all the kit, equipment, they're competent to look after their tube, we've assessed the house, and all their prescription items are unpacked and they've got everything that they need. We provide education to relatives, ward staff, district nurses and care providers in the community as well. And we just act as a key contact and resource. So our caseload has increased year on year. The period for last year, we've got 336 patients on our caseload. We did 104 tracheostomy patients in Nottingham. We did in excess of 800 tube changes a year, and 256 visits. This is really important as well. Avoidable readmissions. We actually, all our patients have our number. We often do home visits in an emergency. We'll try and intercept them coming into ED so they're not admitted onto the wards. And we're usually pretty successful in dealing with the problems so they don't get readmitted. So we're just going to have a look at anatomy. We're not going to discuss because obviously Adam's already covered that, but really just look at some of the complications, indications, and how we keep patients safe on the ward. So within the ENT, it's mainly cancers, surgery. Obviously, I know we've gone through this already. Angioedema, vocal paralysis, occasionally tracheomalacia, stenosis, occasionally foreign bodies. Non-ENT patients, long-term ventilation is great for respiratory wean and toileting in an ICU setting. Occasionally, elective tracheostomies can be done in severe sleep apnea patients. Failed intubation. Sometimes there's no known etiology. And then a lot of traumatic brain injury stroke patients and neuro patients have tracheostomies due to absence of laryngeal reflex and inability to swallow. So there's lots of different tubes on the market. I know at Lincoln and at Nottingham we generally use Traco, which is a standard tube. They come in variable sorts of models. There's fenestrated tubes, unfenestrated tubes, cupped tubes, uncupped tubes. There's tubes with a subglottic port. They all have their own functions, and choice of tube is really appropriate to the patient's condition. And that's really important, certainly in a In a traumatic brain injury or neuro patient, they usually have an unfenestrated cough tube, so we can totally protect them in their way from aspiration. In a patient, they may be able to phonate, and when we've assessed their swallow after the initial insertion, we may change them to a fenestrated cough tube. So initially, particularly in ENT patients, as a general rule, I think we would usually go for a fenestrated cough tube. So this would be inserted at the time of surgery, and this tube will be stitched to the patient's skin, and straps will be applied as well. The reason that we stitch and tape is to make sure that we've got a tract formed, and we wouldn't want the tube to come out for at least 7 days. We change yours to Lincoln day 7. First change. Hopefully by day 7 there should be an adequate tract to be able to do a safe change, and once we've done that change we can then obviously that subsequent tubes remain in for 28 days.
28 days.
Yeah.
Really good.
Yeah, so all plastic tubes are in for 28 days. Silicone tubes and silver tubes, patients can change more frequently.
I believe we do it every 2 weeks, is it?
Almost. 6 weeks for the outside. For outpatient 6 weeks.
Right, okay.
Unless the good legal not.
Recommendations of 28 days, but I think there's a lot of financial incentive for that.
Yes.
We do it for £90 each. Tubes that are left in longer, we do it particularly if the patient continues to smoke. A lot of our patients are drug users. If they have chest infections, when we do remove the tube, if we pushed it for more than 4 weeks, they're pretty bad. And the patient will deny that they're smoking, yet they're coated black. The cuff pressure is really important. I'll talk about that in a minute. So when this cuff's inflated, an overinflated cuff, particularly if the surgeon puts in too much air on the table and is not checked, we know the cuff's up because we can feel the port. But an overinflated cuff could be really uncomfortable for the patient. Long term will cause stenosis and probably a pressure sore. So we use a manometer, which is just a bit like checking the tire pressure on your car, and anything in the green is a safe pressure. And usually these take 7 to 8 mils of air. An underinflated cuff won't do the job. Day 1 post-surgery, we'll probably trial the cuff down on a patient. But again, when we take this cuff down, we don't want to just go along to the patient and when they're lying in bed and they just woke up with the air out. What's going to happen? Everything that's above it is going to drop. It's going to be really distressing to the patient. There'll also be a lot of blood, ready from the surgery and secretions, that's above the cuff. So sit them up, explain what you're going to do, make sure you've got suction ready, and slowly take the air out of the cuff. We can then change the non-fenestrated inner tube to a fenestrated one. So now we've got the cuff down, opened up the fenestration. So if we block this tube, we can see the patient can phonate, and also the patient's now at risk to be able to assess them with a bedside swallow assessment. No point doing it with the cuff up or the non-fen in the tube in. She wouldn't know if they're aspirating or not. So our SOL team will come along on the same day, and the patient will be given water, thickened water, custard, and maybe some biscuits or cake. Everything will be dyed blue, and then the patient will have a bedside swallow to determine if there's any aspiration. It may be that they're not safe to swallow, like a lot of our ENT patients are. The majority end up having a rig, but they may be safe enough to manage their own secretions, to be able to leave the cuff down or to have a cuffless tube. And then most of our patients will maybe go on for oncology treatment with a cuffless tube, but we see them every 28 days. And if we assess them and they've got a chest infection or they're aspirating, we may need to put the tube back in.
So what do you do locally in your center to make sure they are aspirating or not?
Well, we would do a bedside swallow assessment. We would see the patient obviously on discharge at home. we see them every 28 days regardless, so we would check their chest integrity, their tube, their secretions. If they do become unwell, they're giving triggers to be able to, if they've got any signs or symptoms, they will ring us and we will get them in. So we'll try and preempt sort of any problem before it arises to try and get a cut tube in quickly.
But do you see every tracheostomy patient?
Yeah.
Everyone?
All non-ventilated tracheas. Yeah, we've got 130 patients in Nottingham that are on our books. We see about...
I'm saying every tracheostomy, do you see it post-operatively straightforward or?
Yeah, all the NC and Max Vax tracheas, we see them every day on the ward post-operatively.
Oh, okay.
Yeah.
That's very good.
Yeah. Occasionally we might need a subglottic tube. Now this we've got the cuff on. There's also a second cord that sits above the cuff. So if somebody's secretions are really severely aspirating, what that allows us to do is be able to draw off any excess secretions above the cuff. These are quite good as well in end-of-life patients who want to risk feed. So they're desperate to have some tea or coffee or sips for comfort. We can let them drink. Fluid will sit there and it can blow it off. So, and occasionally in laryngectomy patients with a fistula or a tracheostomy patient who's end of life that wants to risk feed, we put a subglottic tube in.
So you don't use a tracheal subglottic tube as a routine?
Not routine, no.
Because it's more expensive, I believe it's
Yeah,
30
yeah,
or
£30.
over by 80.
Yeah.
Here they put it as a routine.
Yeah, they don't listen to us. We say it's very expensive, but they don't listen to us.
We got it from the actually we got the tracking side. Most of the for the emergency, yes, we do it, but most of the elective tracking, actually they give us
The ITU, it is, yes, it definitely needed the ITU because they need suction all the time.
Yeah.
But for our patient, the patient is awake from day one, so
Yeah.
saving 40 quid per patient.
Yeah, there's no need, unless it's a clinical indication, I would say no. And then down the line, if you feel it is needed, we could do it.
You can do it, yeah.
Yes. We can make the cup of coffee as a routine, but not as something.
Yeah. Yeah. Again, if somebody comes into ED or you're going to review a patient, all the identifiers are usually on the front of the tube, on nearly all tracheostomy tubes, so we can see this is an 8, fenestrated, all the diameters are here, and we can see it's a cuff. In Nottingham, and I'm sure the same at Lincoln, we have Medway alerts, so all our laryngectomy and tracheostomy patients have an alert on our sort of hospital systems to flag, and all their tube changes are documented. So obviously somebody could go onto the system to have a look when their last tube change was, and we have our own documentation as well. We work closely with the critical care outreach team. So all patients need to be humidified. There is an argument whether they all need cold humidification straight away, even if they've got no oxygen requirements, but generally we put them on oxygen humidified for the first 24 hours. We try and wean them as quick as possible. If we're not waiting on a rig and it's straightforward tracheostomy, we can usually turn them around within 7 days to get them home. And that's with all their kit, equipment, that first tube change, discharge within 7 days.
Really? Okay. It's good. It's very good.
Obviously we give them some sprays, the saline to spray directly down the tube. They have little filters that trap the moisture in the air. These called HMEs. But humidification is really important. The most common complication is obstruction, and that will be for mucus. But if a patient can't cough a mucus plug through here, essentially they could die or they could go into an area compromise. And this would usually happen at 2 in the morning when it's a junior doctor on the ward at a weekend and the patient's got a massive mucus plug that you can't move and they're hypoxic. And maybe day 2 or 3 post-surgery, it takes a bit of balls to take a tracheal tube out, maybe after a couple of days of insertion. And again, the relative humidity, as we breathe now, our air is 97 degrees Fahrenheit, it reaches the lung. In a neck breathing patient, it's 67. So mucus plug-in is really, really common. Cleaning, again, make sure you use sterile water. They use boiled water at home. Sterile cleaning products and sterile cleaning swabs. Non-toxic said, and suctioning. So again, make sure you use the right suction catheter, the size tube. You look at the size of the tube, you times it by 2 and take away 2. So an 8 would be a 14 catheter, a 7 would be a 12, and a 6 would be a 10. The emergency equipment is really important. Bedhead signs, again, for the anatomical differences, green for tracheostomy, pink for laryngectomy. The emergency algorithms are on the back. Everything in the blue box is by the bedside that you need to do an emergency range. We check that equipment every day. And even though you've got a spare tube in there, if the tube's stitched in and the cuff's up, somebody might have took the syringe out. So it's really important that we've got stitch cutter, syringes, lubricant. And in an emergency, we'd always say go for the smaller tube. So if somebody's got an 8 in, there'll be an 8 and a 7 in the box, just put 7 in. Laryngectomy patients all have a 6 unfenestrated cuff tube that obviously we would put into their stoma, inflate the cuff, and then we can bag them. And then obviously we make sure we document everything. These are the emergency algorithms on the back of the bedhead signs. So obstruction is one of the most common complications. Again, blood, secretions, hemorrhage. Again, I know Adam talked about the thyroidismus, but again, it's quite normal to have minimal bleeding after a tracheostomy. Maybe the tube's not sitting right. We might need to scope the patient and just have a look to see where it's sitting. It might be rubbing. We may be a bit rigorous with the suctioning. Maybe there's a bit of an ooze from the surgical site. Any sort of moderate bleed obviously the patients may need to go back to theatre. Tube dislodgement, we'd hope that the tube wouldn't be dislodged if it's stitched in place, but occasionally patients do pull, and so we need to keep them in a close observation area, make sure we put them in an airway bed on the ward, which is sort of close and visible. There might be trauma to the tracheostomy site, but usually if it's been done electively, usually the site's quite nice and usually heals quite well. It's usually dehisces when it's been done in emergency and the incision's a bit bigger. Infection, I mean, again, nearly all trachea patients get infection. We're doing a lot of work at the minute at Nottingham around having a standard operating procedure where all patients go on IVs post tracheostomy. Because I think we've looked at a sample of about 70 patients and over 90% of them developed HAP. Again, you've lost your PEEP. The way that you breathe is very different. You've got a front body in your neck. We're sticking suction catheters down there. And usually within 24 hours, their chest secretions often change colour. So we need to get septic screening, sputum samples, and we end up starting them on tazocin usually.
So you use routine IV for how long?
It's usually sort of 5 days of IV. Tazocin.
Okay. I'm sorry, I'm just getting comparing the experience. For other surgery, basically the thyroid, you do use antibiotic as a routine?
No.
Frozen, this is open. They treat it as an open lump, so like orthopedics.
So up to now, we don't use the antibiotic as a routine unless there is an infection afterwards.
Do you find your tracheostomy patients get?
I haven't noticed, well, possibly because of other reason. Some of them we do the trachea for the IT
Yeah.
team, or where the antibiotic is present anyway.
Yeah. They may be on them anyway.
Yeah, so this is one of the things. Or any patient go to the ITU will receive antibiotic, and one of the things many of the patients, if they have many comorbidity.
Yeah.
And we doing awake tracheostomy in the first night in the ITU. This is interesting point to look after.
To be honest, I find it, we are not the people that give the antibiotics. It's usually because they are like advanced cancer, aspiration. So patient comes usually with especially the crash one.
Yeah.
He's already chronic patient.
Yeah.
So he's DSATs, but he got a lower chest infection. So they cannot clear up the chest. So we do emergency trachea, or the crushed trachea,
Yeah.
not because they see desaturation, it's just because they cannot do the chest toilets thing.
Yeah,
So
yeah.
automatically they started with an antibiotic. So, but it's good to look
The
in.
difference between us and you. I believe most of your patients are pure head and neck. They are head and neck cancer. The trachea, either it is designed as part of the procedure, especially with salvation,
Yeah.
or it is done before the procedure to guard against airway. Here, I believe I haven't done any, I believe Mohammed is better than me, is better in statistics. We haven't done any statistics, but I believe 80% of our patients coming from the ITU
Yeah.
at any time, and these patients, we haven't noticed because most of these patients already they are on antibiotics. Patients, the pure head and neck ending by tracheostomy, because we do a lot of the briding procedure during the surgery. So if you have an airway which is jeopardized during the surgery by a huge mass, we just the briding.
Yeah.
Mohammed is very famous for the cooperation. Create a road, a new road.
I think the data we looked at was predominantly head and neck cancer patients.
Yes, that's what I'm saying.
Like you say, they probably by the time they present, they've probably been aspirating a while anyway. A lot of the max fax surgical tracheostomies don't end up with pneumonias.
Yeah.
invariably.
I usually get a patient aspirated, I push the trachea. I
Yeah.
put my ankle suction side before I open the trachea, and sometimes also
Just get
I put the trachea and no she's the trachea,
yeah, yeah.
Sorry for the interruption again. So
That's fine.
for the obstruction and the tube discharge, is that's need a doctor to be around to do it, or just a nurse that being trained to?
No, I mean,
So they have a problems with this, to be honest. They prescribe the word that it should be trachea trained. We find that they become more panicked and they have to grab one of the doctors and things like that.
again, I think it depends what ward the patient's on, which staff are on, when it happens. We would say that within our units, if it happened during Monday to Friday when we were around, we would take over and do the tube change. A lot of the senior nurses on our ward would be involved with that. But obviously, if it was all our patients on another area, they'd probably would just be BNT doctors or two.
Again, it's different in the hierarchy because you have a job included as airway specialist nurse,
Yeah.
which we are fighting to do here.
Yeah.
We're fighting to do two things: airway clinic and airway specialist nurse.
We don't have it.
So if you are Monday to Friday, 9 to 5, and you have a ward, they can call you here to be the nurse in the ward. Some of them are not happy or not confident to deal with this situation, so she will panic to the junior doctor. With all respect, some of them may never have a tracheostomy before, but claiming he's a doctor, see, he knows better, and that's it. This is how the game plays. Try to bring the concept of airway specialist nurse and airway specialist clinic. It's a matter of fun.
It's in the plan, the plans in the fund, so the respiratory is involved, the IT is involved, and the surgical team does not want to pay for it by
The
themselves.
amount of money you can evidence, sorry, we're going off piece a bit now, but I think really when you look at avoidable readmissions, when you look at getting patients very early, when you're looking at the support you give these patients, with
The argument is quite very strong.
yeah,
Because many of these patients are booked to the consultant for the track change. And the slot in the consultant, you save it. This means you save a lot. If you have a consultant sitting, you have a nurse sitting, you have a lot of admin behind, secretariat, and just save this slot, and one person will do the job is done. Thank you. And that's it. I'm sorry.
yeah, no, that's fine. I'll be quick. Focal cord part. So obviously, if there's any damage to the recurrent laryngeal nerve, so long-term complications could be stenosis, fistulas, or tracheomalacia. So again, we're seeing a displaced tube here between the sternum and trachea. Looking at the patient, we think the tube's flushed to the neck, but it's obviously in the bulge tract. This is one of my ladies who smokes crack cocaine for a tracheostomy tube, and she won't wear a tube. She went to the changes on her every week, and this is just a big fireball, and this is just a big crust. We're going to do the scenario later after, so we'll do obstructing tracheostomy, and we can maybe do it with the dummies, and we can have practice. We generally see my ENT patients, they're usually very compliant with their tube changes. They will hold the breath, they will put their head back, and they're quite cooperative. But the nature of their disease often means that it can be quite complex. If there's tumours encasing the tubes, or overgranulation, or there's fungating neck wounds. So ENT has their own challenges. And again, a lot of our patients get classic overgranulation, which again needs to be excised. But we're very fortunate that we work really well with our head and neck consultants. We're very sort of autonomous in what we do. I know from Adam working in Nottingham, I think really when registrars contact us, when you've had referrals, we'll often pick those up and go and sort them out. So I think really sort of is something you could probably do with here. But when we're trying to teach our patients, obviously younger patients are very physically able to look after their tubes, they psychologically struggle. Older patients are physically accepting, psychologically accepting, but physically struggle. But the analogy is, if you can thread a needle, put a cork in the bottom of the straw, you can cut the trachea. It's easy. We don't do this. So sorry, I overran a bit.
Oh, no,
Thank you.
Just quick question, is the Negus tracheostomy still available or?
No, they don't make them anymore. I have a supply, I have a big bucket full of Negus tubes that are all but there is another manufacturer that generally go for silicone tubes now.
Very hard to convince it. Patients and the need is important. It's twice time, and there is a couple of them I refer to you to get your second opinion on them, because he insists on the Negus, saying it's much less infected. I kept saying it's not available anymore.
They're the most amazing tubes ever, but again, they're £600 each. Forever. £1,200. But obviously now we're living work where
One Negus and
gold one. Wow. Never seen a gold one.
We'll have 5 minutes of small presentation of the track team about what's the types of the tube that's available. And then we've divided ourselves to 2 groups. So say this is group A, we'll go for the nasal biopsy with Mr. Salim. Then we have group B, we'll start with Sue on the trachea scenarios and the change, and then we change it. We'll have like another 5 minutes, 10 minutes, 10 minutes, 5 minutes for the rest. So, and then let's make it like 2:45. So on 2:45, we're gonna start. We'll have 45 minutes and then 45 minutes. Is that okay? So make it an hour and a half. So we'll say that 4:30, we need to finish. Everyone needs to go home. We don't want to keep everyone. It's concise. I know we used to put it in the airway, but the airway course become more towards the surgical technique. So we'll have the rabbit neck on the pediatric tracheostomy, and then the adult and the pediatric bronchoscopes, and then the front neck on the big larynx or the sheep larynx. So be more on the surgical time. So we decided to take these bits out to make the surgical time on the other side better. So I hope to see you in December for that. Thank you. Okay, thank you, Betsy. I'll leave this for you.
Thank you. Hello, everyone. My name's Betsy Grant. I'm from 1'st Medical. So we supply all of your tracheostomy tubes. So you may have seen them. They're called tracho tubes. So I'm just going to run quickly through the differences because there's two types. We have the twist and the twist plus, and there is some differences between the two.
You can put it down.
Yeah, thank you. Okay, so this is the twist. So the twist is the oldest range that we have, and these are just the product codes. So I won't go through them all with you, but there is some differences between the tubes. So we have the 301, which is with a cuff and no fenestration. Then we have cuff with fenestration, no cuff, no fenestration, and then no cuff with fenestration. So there's lots of variables. With a cuff, no fenestration, with subglottic suction, which I will talk about in a moment. And then all singing, all dancing, cuff, fenestration, and subglottic suction. So they're the different types in the twist range. And then the Twist Plus, this is the newest range. So there's a few differences with the Twist and Twist Plus. But with the Twist Plus, you'll see the codes mirror that of the Twist. So a 301 becomes a 311 if you're selecting a Twist Plus. So it's the same with cuff, no fenestration, etc., etc. You're not going to remember all of these. We have product catalogues, etc. So you can take a look, decide which one is best for your patient. So you can see pictures of the different types here. You'll see the ones with cuffs, you'll see the ones with the fenestrations here and with the subglottic suction as well. So depending on your patient, you're going to select what is right for them. Some patients can't tolerate their cuffs down, they need their cuff up. Some patients are good with a fenestrated tube, some patients not so much. So it really does depend on the patient, what the secretions are like, etc., etc. So just to remember that blue is fenestrated. So if you see blue printed on the neck flange, then it's a fenestrated tube. It's got holes in it. Okay, so it's really important to know that. Okay, so this is lots of technical information about the tubes, but I think the thing to really remember with the tubes is the inner diameter of the inner cannulas, because it really does make a difference to that patient's airway. And then the outer diameter of the outer cannula to make sure you're going to get a good fit for your patient as well. So as I say, there is a lot of technical data there, but you can always look it up in the brochure again when you're selecting the right tube for your patient, because the millimeters really do count with the tracheostomy tube. You really want the biggest inner diameter inner cannula that you can for your patient to give them the best airway. So this is with the twist, and that's with the Twist Plus. So with the Twist Plus, the outer diameter of the outer cannula is smaller, but it has the same inner diameter. So we measure all of our tubes with the inner diameter. So if a number 7 tube, it'll have 7 millimeters of inner diameter of the inner cannula. Okay, so if you choose a number 7, they're going to get 7 millimeters in that inner cannula. And this is what really counts. So patients, if you select a size 8, will get 100% air with a tube of a size 8. If you went up, increase that to a size 9 tube, they would actually get 60% more air and with the same effort of breathing. If you reduce that to a size 7, it's harder to breathe for the patient and it reduces the air by 41%. So that's why it's really important if you can get the biggest size tube possible for your patient, obviously depending on the patient and their anatomy, etc. The millimeters really do count when it comes to tracheostomy tubes.
I usually ask as an anesthetic consultant, what would you like me to do?
And they will tell you.
Yeah, so yeah, it's not with the cuff up. No, it's not with the cuff tube. There's 41% less.
Yes.
With the cuff up.
Yes.
Yeah.
What do you think, Mr. Salam?
Yeah, they say, it's an easy way, ask the anesthetic which tube is using, just match with the same size.
Yeah, absolutely. And I think when weaning the patients, it's important as well. So, especially with some of our tubes, you can have a fenestrated cuff tube and they can have that tube throughout their hospital stay. Maybe if they're in for a month, you can use that tube for 30 days. So you can just use one tube instead of having to do multiple tube changes and maybe changing the tube. So again, it does depend on your patient and what's suitable for them. So all the tubes have a 15mm connector on the end as well. And when you look at the flange, it will tell you the information that you need to know about the tube. So it will tell you the inner diameter of the inner cannula and also the outer diameter of the outer cannula. And then if it's blue, it will indicate that it's a fenestrated tube. Okay. So hopefully just at a glance, you'll be able to get all that information from the tube on the patient. So the difference between the twist and the twist plus, as I was saying, and you can see it highlighted here quite nicely, is that the twist plus just here, if you can see, a size 9, the outer diameter is 12.1. With a twist, a size 8, the outer diameter is 12.7. So a twist is a larger tube on the outer diameter, but it gives you less in the inner diameter of the inner cannula. So really the twist plus is a superior tube. It also gives you extra distal length as well. So if you have patients with maybe short stubby necks or they've got lots of adipose tissue around the neck, then the twist plus is a good option. It does tend to fit more of a range of patients than the twist.
The difference in millimeters, it's not so long, it's few millimeters.
It is, yeah.
So if I have a chunky neck, you have another tube, because I'm sorry to say that, because I was the one looked to your catalog. There were another tube which is compatible with just for flanges, which is much, it's 2 centimeter long.
Vario, yes.
You have Vario.
We have the Vario, yes.
Yeah, you haven't used that in the right way. There is another one I discovered inside the catalog, which your recommendation to change it every 3 months is double the price for
Comfort.
comfort. That's, you don't promote this one as well. This one, which manufactured by one, it is certain material.
Yes,
one by
very
one.
soft.
It's soft. It's a 3 months. So if you calculate the price for 3 months rather than 28 days,
Yes,
you will end by it's
about relative. Yes.
It's still okay, and it's much comfortable to the baby. It's much softer to the
Very
baby.
soft, yeah.
I don't know why you don't promote these two.
Yeah. So
I'm not.
come and get a job. You're more than welcome.
Is expensive. But we would maybe 6 months down the line, if the patient is going to have a tube for maybe 6 months for a longer period of time, then we would think about a longer term silicone tube like a Comfort. 2 tubes will last them 6 months.
Yeah.
And if I'm right, they're a couple of £100 each.
Yeah.
And Lincoln 2 tubes will last 8 months.
Yeah.
12 months.
And they're customizable as well. So we hand make them over in Traco in Germany, and you can choose exactly all the different customizations of the comfort that you want. So you can have them very short, very long, wide. You can have all different things. So they take about 8 weeks to make, and they do cost, as Sue said, a couple of £100. The customizable ones even a little bit more than that. But when you've got long-term trachea patients, they're really good.
Customized will keep it for the what's the main customer for Nagus tracheostomy or for everything.
I think that's why we made the comfort, is because of the Nagus.
Yeah, because Nagus becomes a nightmare. Now to replace it, but I believe comfort is a good thing. And my own recommendation when we get the value, dealing with one company is much better than dealing with more than one company. It's a way to make up again later on.
Yep.
So if you promote it, happy to take it.
Yes.
It's the comfort and the value.
Yes, so the comfort absolutely is available. The Vario we do still sell. It's very popular on the continent, but because it's a single lumen tube, people are a little bit adverse to using the Vario.
Okay, so you don't have Vario W.
No, we don't.
Still, the double phalanges would be the best.
It still would be. Okay.
I think we're not allowed to use.
Yes,
single
it's a new
picture.
regulation.
Yeah.
Again, it's like this.
Thank you. Okay, so just a few features and benefits with the fenestration, double fenestration, extra distal length, colour coordinated inner cannula. You can see the top one here is the twist, and this is the twist plus at the bottom. So they're both fenestrated because they're blue. The twist is a solid 15mm connector. The twist plus is a ring, and that is a locking ring. So patients in ICU, if they're ventilated, there has been sometimes the twist has come off of and detached from the ventilator, but with the twist plus, it has the locking ring, so it cannot detach from the ventilator. So it's just an extra safety feature we introduced with the twist plus. And then extract is our subglottic suction tube. So if you've got a patient that's struggling and they may need that subglottic tube to get those secretions away quickly, then we have that option as well. The twist and the twist plus both have subglottic options. And it does it has a larger flow cross section. So what that means is with the twist plus, you can really get the secretions away quite quickly, and all of it as well. So with the twist, when they were doing testing, we found that there was still a bit of secretions left after aspirated, but with the twist plus, actually it comes out very quickly and we get all of it out as well. So that's the difference. And there's a picture, so you'll see that it has that extra tube on the line here. So it's quite easily identifiable that it's a subglottic tube. Just a little bit about HMEs. How are we for time? Are we okay for a moment? Yeah. So I've got 2 more minutes. Yeah. Oh, we've passed. Okay, sorry. Just a couple of minutes then. So HMEs, heat and moisture exchangers, they have a 15mm connector to go on the end of the tracheostomy tube. This is the track phone. You can voice with this HME. You can suction straight through the middle of it as well. So if the patient wants to voice, you just depress it and they can voice, and it also provides humidification as well. Greetwell Ward are currently trying track phone because they really like it, and hopefully it will be hospital wide soon. And then Freevent Extra Care, this has got filtration, so if patients are at risk, this adds an extra layer of filtration. And then that's just a close-up view of how the filtration works with the HME. You can't talk, you can't voice through this, it's just a HME. You can also give supplemental oxygen through it. And then dual care is a HME and a speaking valve, so you can do both. And then you've got your Passy-Muir valves as well, so your speaking valves. Okay, that's me done. Any questions? Thank you. A good question. We don't, but yes, I think. Is there glue?
Yeah, that was actually but it's double tube. Yeah. Maybe you'll get onto R&D again later. Out in the town.
I'll come with you for a second. Are you Is that the scenario?
Yeah.
You sign, did you sign? You need to sign everything.
Hi, how are you?
I've never seen you going scrubs.
All right, what have you been doing? Just clinic. Oh, yeah.
On the first one. Let's see.
Yeah, most of them.
Like no.
I used to say, like 6. The wake up. So
Set up with them.
yeah. Yeah.
They asked about it. I'm not sure they're going to wake up. That's where I need to go. Really good. So they're also on their dead. So they give them too much. They can't break. Just got it. Yeah, yes, the same.
Sister there, what's her name? I really thought it's Michelle.
Yeah.
Yeah.
Yes. So I want to go and so that I can know it's Adam can go and get through the virtual steps.
Yeah.
There's something that yeah, she went to use that. So when she went to I then now.
To me, very
Now when they get right, it's really good. It's because of the hospital. Yeah, I mean, we came downstairs. Yeah.
the contact for the second.
Yeah.
basically sliced former consultant. Yeah.
So, can you send your post?
Yeah.
Send it to me and I'll forward it to you.
I am happy to give it again at some point, so not today.
When we've got a lull in between patients.
Yeah.
We'll do it then.
Do a little round table.
Yeah.
You're all right. Don't.
Yeah.
I might, yeah, I'm trying to go at least once a week. And then I will retire from theatre and then going on.
On the skill is going.
Yeah. Yeah, oh yeah. They don't put much in it. I think you might have been there for a minute. Oh. Oh, yeah, I mean, rest now. I like it.
Nobody.
Must give it to know. Rest. Yeah.
I don't go in there enough.
However, you know what we
I think you're well, it's just me and might have been Manuel.
Once you're done with the sheets, just put them on the front.
Oh, it's the New Year's after our chat.
So leave the everything's on the scopes themselves.
I'm loving it. Oh my God.
The undulating lever at the top just here.
I agree. I mean, I
You have two wires that essentially run down the inside of your hip. Wires. It's one mechanical here, where your four fingers will go down, try and feed them down nice and gently. You also then have a suction channel here. You need it, it's activated using this brush. I'll leave it to ask you about how this to.
What did you answer? There's nothing.
So it's 5 minutes.
My apologies for the lateness.
A lot larger than this normally.
Sorry.
It's the
Somebody.
When you're passing the button for things down, they operate using this button range just here. And this. Today, they're allocated. That's not normally using other files. We're going to start here. Hold visual locked and pass them down.
Only the little clearly, but somebody would want to try.
Not extended.
Maybe they come back from the courts. All of a sudden medical hypoxia, and we're suspecting that there's an obstruction of the lungs. So what's we going to do? First thing we do. First thing we do is just quickly take in your breath. You'll see the age is
Blocked. And if you look on the screen, you can pull your back.
That's not blocked.
You can see exactly where the doors are.
People think, rooms are for the region.
And I would say we've
But
got.
as I say, you need a percent
A few things
Yeah,
before we.
yeah,
go
makes
on.
sense.
Yeah, completely.
The first thing we're going to do is we're going to structure.
So if you look at the biopsy coming from here,
Don't worry,
it's
it's
very
down,
tiny
and
structure
when you
on.
go down,
Yeah.
suction.
And sometime
We
you
need
need
to
this,
establish you can
you
feel.
need a deep biopsy. So what I do, I take a biopsy in specific place, and then I spray the deep in, and then I go deeper in the same area I done the biopsy, right?
Down.
And I done it under suction, so I can get the deepest clearance.
We're then going to get some daylight and we're going to.
But we have-
Mills.
A scope here, you can use forceps, you can constantly do forceps downward like then, and also we have a model here where you can actually do the scope.
There's no result.
As I said, they are alligated forceps, so you won't actually put things in your forceps, but it actually gauges the feel of it.
Helps on the way.
That's also-
Come in, hold your edge. Somebody's got to give a new tube ready. It dilates.
Probably a little bit, yeah, it's just difficult.
And once we've done those 5 things, if there's no result.
Gonna be any clearance from the end of it.
So we trying to think what he did this. Separately, the second one was tied on the model there.
Yeah.
That can we put small pieces of.
We haven't put anything in there.
Yeah, I can just see that.
Kind of spray, nothing.
Yeah. He's good. Very good.
Oh, no, sorry, that's my.
I'd say it's like half heavy.
The breathing, if the plug is solid and it's not resolved itself, really it's something is on the deep. Get as far as removing the tube, trying to remedy the problem, putting a dilator in or a new tube in. But beyond that, if we can't resolve the problem, then it moves the waste. So we're going to assess the patency, remove the inner tube, suction, deflate the cuff. There's still 2 mils of saline. Suction again. Repeat your assessment. If it's still not breathing, you will need the tube. And then it's the oxygenate, primarily if you're trying to
Only the first years.
What's the inactive name to the
Just trying to see.
Okay, so remove the inner tube, put the inner tube out.
Not the space grade, the size.
So remember, we are using this section for all the way down to carry.
Yeah, I would just go, normally with a shallow suction, you go to 12 centimetres. The emergency just go to.
So, where's the display? Go down and
Which
you need to give hold of the neck flange. Yeah.
To Lawrence and Brad. The whole thing with him, I was really proud of myself. And then I was like, why isn't the patient breathing? Yes, because I completely forgot about introduce it. Unless he introduced.
did you record?
What is the part? Yeah.
Is that the same protocol for the even the day?
Yeah.
No, the other side.
Yes, I know it. To the right.
To the right, yeah, yeah. So that way. Well, place it.
One lock.
Do it again. Spot to the. Yeah, there you go. Just put it. Saved it.
Yeah.
Promised today.
Still alive.
Yeah, and even the elastic is not the best.
Yes, you can see there. you can catch up.
We generally always want to
Close it down. I think it's probably
The patient is doing.
or they
Just all the living issues.
Well, they did the minute, yeah. He's just doing it. So that's bringing an expensive to the next exam. But over time, I think she just got again, we never, sometimes you can go away and then come back. But it's generally speaking, we just make sure we've got oxygen saturations on the patient, got emergency rooms available, and the YouTube rooms go in now. We need to do that. Again, we work at lots of different ways.
Inside out. So you don't want to continue to do
Still, is protocol, isn't it? Yeah, we are still, we are following the 5 days. But apologies, isn't it? Yeah, what is the reason for the?
You know, it's a medication for the neuro patient.
Maybe that's a, you know, 20 years ago, I think there was a people. Oh, that's structure. No, yeah, I think that's it.
There is no.
The station to the speech box. Then, second day, then 9, day, so they suppose they could start with the speech box. That's speech box.
Nature and hormones you continue to go to be
Great.
of course, ask you.
Is it the same protocol they are following?
Monitor the CO2 condition and oxygen. They have their lungs focused. So they may
Supplers to hold the patient.
so it's more was a longer time in a trial of
Measuring the response there.
Not sustainable. And a lot of times they say Friday, and at the foundation, on Friday. After you say they film and then they give the mission like another 3 weeks and come back again.
There is a lot of politics in the sense of we
Nice, don't control it. To be honest, because they are practice, and if we give it a right, not our because the question at the start was the longest okay, just let him on the air. And then yes, that's it. There's no
You can see the lot now.
بس هي فليكس مش فليكس زهقت الثاني بيدخل معاه
There is no protocol. And it works really well actually. And I was like, okay, well, I know you come to this course. So,
yeah, they've already asked me. The Mo's going to email me
Yeah.
and I think it's very when CNS
it would solve what's the problem.
then say that you've got responsibility for CNS. Liaise with the
If this is a temporary, like, patient will come in. Okay, far too long on the ward, because no one's confident in the rest of the regulation. The idea of this was just that it tick the box, and if they don't tick this box, like,
Friday, you know. You put your, you put where you want to I'm sure you get someone nice. The same with the pediatric acute with the surgical teams and nursing protocols. We go through things
So this becomes relevant to you because you can have a few of these going. Yeah, so what you will need is.
No. Can you see the long left? Yeah.
But essentially, like the setting on use going,
Can you close it now? Once you get the work, you close it. And then things that helps you on site.
So I also show this, you try and feed biopsy forceps.
لا بيعمل حاجه مسمنه اذا في اطنش طنشت منه مرضى انك تطلع
بس
Worst case scenario. You will lose it. There's no way to. So what you're going to be doing. Do your bottom, you buy support, raising and draw.
And then just really tough. We can shoot it to
laser and airway.
And then from there you.
Yeah, but
More than 24. I put on waiting list. So
we can just get it.
yeah, you know my email. Send me
Yeah.
the email today. Okay, I can put on.
Yeah.
You want to attend? You want to attend?
Would you like that?
You would like to.
Yeah. So laser third
Actually,
airway December, 4th of December is Thursday. Yeah.
If you want to attend the airway, send me email today.
So you will.
So what I do now, on waiting list. Yeah, if there's any consultation, I'll let you know as soon as possible. Just put me in an email. Okay? Okay, this one has. So what, food.
إنسان we are working Yeah, well done. Do you advise the yeah.
Here's the mic. Yeah. Yeah, come on. What's the good name? Why not?
So just office receive about there's a one on way to myself. It's good finding you something.
Yeah.
Well, the reason is, you remember when they.